So welcome everyone to this Preventing Overdiagnosis webinar about how researchers and policymakers can work together to reduce low-value care. We're going to start in just a minute. Thank you so much for joining us. We're really looking forward to this conversation. So welcome to those people who've just joined us. This is a Preventing Overdiagnosis webinar focused on how researchers and policymakers can work together to reduce low-value care. And we're about to start in just a minute. We'll just give people a little bit longer to join us. Okay, so I might pass over to Professor Katie Bell, who's going to introduce the webinar today. Thanks, Katie.
Hi, everyone. Welcome to the Wiser Healthcare sponsored Preventing Overdiagnosis webinar. And as Stacey mentioned, the topic of the webinar is how researchers and policymakers and actually health service providers can work together to reduce low-value care. And we've got a really exciting lineup. I'd just like to quickly introduce myself. I'm a professor of clinical epidemiology at the Sydney School of Public Health, University of Sydney, and an investigator with Wiser Healthcare. And I'm co-hosting this with my colleague, Stacey Carter. Do you want to introduce yourself?
Hi, everyone. I'm a professor of empirical ethics in health at the University of Wollongong. I run a centre called the Australian Centre for Health Engagement, Evidence and Values, and I'm also part of Wiser Healthcare.
Excellent. And so we've got a really full seminar ahead for the next hour with some great presentations. So we won't take too long before we get straight into it, but we've got 3 speakers from either policy or health service provider organisations, and they'll each speak for 5 minutes. Then we've got 4 researchers joining us for a panel discussion to talk about the experiences from the researcher side. And then we'll open up for a Q&A. And we'd like you to use the Q&A button, which should be at the bottom of your screen, to post any questions that you think of during the presentations or the panel session. We've had a couple submitted during the registration process. So I can see that someone's raised their hand, but if you could just write your question into the Q&A button, and then we'll have time after all the presentations and the panel to answer things. Okay, so over to you, Stacey, to introduce our first speaker.
Thanks, Katie. And I just want to make sure that everyone's aware that the session's being recorded and it will be posted to the Preventing Overdiagnosis YouTube channel so that people will be able to access the recording afterwards. So I am very excited to introduce our first presenter. So Dinah Schramm is the Acting Director of Behavioural, Economic and Engagement Section at the Department of Health and Aged Care. And Dinah is going to talk about partnering with Wiser Healthcare to evaluate solutions to reduce overuse of musculoskeletal imaging. So thanks so much, Dinah. Over to you.
Thanks, Stacey. So diagnostic imaging for people with musculoskeletal conditions is overused in primary care in Australia. This increases the risk of harm to patients from overdiagnosis and overtreatment, particularly from the cumulative exposure to ionising radiation. To address this, we conducted an 18-month randomised control trial in collaboration with Wiser Healthcare. Due to its factorial design, the trial evaluated both the overall effect of feedback to Australian GPs for reducing overuse of musculoskeletal imaging, as well as the effects of 2 factors hypothesized to increase feedback effects. They were how often feedback is provided, once or twice, and how the feedback data is displayed, standard or enhanced display. Prior to this project, only a few studies had used audit and feedback to target the problem of overuse of musculoskeletal imaging, and these studies had small numbers and non-tested ways to increase the effective feedback. We co-designed and iteratively refined prototype feedback letters, exploring potential ways to increase its impact and drawing on evidence and theory about how feedback works. Next slide, please. The trial found that providing feedback to high-requesting GPs at a national scale reduced musculoskeletal imaging requests by more than 11% over 6 months. This graph shows GPs receiving feedback in the solid line, and the no intervention control group is the dashed line. The feedback led to statistically significant and clinically important reduction in overall imaging requesting at 6, 12, and 18 months compared to the control group, with the two factors leading to a modest additional reduction in imaging requests. We estimate that the feedback led to about 47,000 fewer scans over the study period. Next slide, please. This collaboration was beneficial to both the department and Wiser Healthcare. The project was an efficient way to conduct a large-scale trial to optimise and evaluate solutions to reduce low-value care. It was innovative, an evidence-based approach to program improvement, and we maximised the impact to reduce low-value care. There was capacity building and reputational benefits for both sides. The department benefited because we were able to broaden our scope, as we typically rely on quantitative research, but thanks to Wiser's expertise, we were able to bring in a qualitative research component that upskilled our team in user testing. Stakeholder management was also a major component for the department. The project really demonstrated the value of getting the end recipients of our letters involved in the design and development phase, and resulted in several significant improvements to our end project, particularly on what we were testing and why. The department also benefited in terms of reputation by collaborating with experts in overdiagnosis and publishing in the Journal of the American Medical Association, which provided a robust and independent peer review for us. We achieved a policy goal as well in terms of increasing the sustainability of Medicare. Wiser also benefited as collaborating with us gave them access to rich data, a nationally scaled trial, and expertise in Medicare. Overall, this contributed to new knowledge as the intervention factors evaluated in this project were shown to be effective and can be incorporated into future feedback interventions. So some of the challenges. Aligning our policy and research outcomes takes time and a depth of understanding of each other's work. It requires a shared mission of what you want to achieve. You need to have clarities in the roles, responsibilities, and the project governance. We managed this through a research collaboration, which was also one of the first for the Department of Health and Aged Care. The agreement considered the legal, data, governance, privacy, ethics, financial aspects, and the publication agreements as well. This provided the structure, assurance, and support to this collaboration for the department and Wiser Healthcare. Another added challenge was changes in personnel and team expertise over the length of the project, which had commenced in 2019, with publication occurring in late 2022. Lastly, I just wanted to say that this has been a very successful collaboration that's contributed to improving implementation science through an evidence-based approach, promoted trust, knowledge, and opportunities for ongoing collaboration. So thank you very much, and back to you, Stacey.
Thanks, Dina. I think I'm taking over from
Oh,
Stacey
you're over.
to introduce the next bit. Thank you. That was a brilliant presentation. There was a bit of background noise, but it seems to have resolved itself, I think. So we'll move on to the next of our presentations, and I'd like to welcome Mr. Nick Ormiston-Smith, who's the Program Manager for Epidemiology at the Cancer Screening Unit in Queensland Health. And Nick's going to speak to us about their project of running a randomized controlled trial in a real-world setting. Thanks, Nick.
So good afternoon, everybody, and I'd like to acknowledge the traditional owners of the lands that we're meeting on today, and the elders past, present, and emerging. So we had a trial looking at the psychosocial outcomes and health service use in a population of women with dense breasts. Next slide, please. So just as an introduction, breast density is important because breast density is associated with an increased risk of breast cancer, and mammograms are less sensitive in women with dense breasts because the density can mask the appearance of breast tumors on a mammogram. But there's no consensus on the use of supplementary screening tests for women with dense breasts. So it's difficult to provide evidence-based information to women who have dense breasts, and that has led to notification being controversial both in Australia and worldwide. So in the US, there are several states that have made density notification mandatory, and it has been notified in Western Australia for several years, and there has been over the last few years I guess a concerted campaign to increase breast density notification within the program in Australia. Next slide, please. So in order to assess the effect of notifying women about their breast density, we had a randomized controlled trial with 3 arms. We were aiming to include 2,800 women, initially at the Sunshine Coast service, but also at the Brisbane North service, and only those women with dense breasts were included in the study. We also had a qualitative sub-study where we had semi-structured interviews with about 60 women, and we did some additional research for culturally and linguistically diverse women, and we're also hoping to do an economic analysis based on the health use as well. Next slide, please. So the partners in this work have been the University of Sydney, the Cancer Screening Unit where I am based, and the Sunshine Coast and Brisbane North side PSQ services. So we've had a range of viewpoints that have come into the study. So the University of Sydney brought that academic rigor to the process that is obviously valuable. They also brought funding that enabled us to do the trial, and we were able to fund additional GP engagement and GP time and medical officer time to manage the survey. The Cancer Screening Unit in Queensland brought the policy context, an understanding of the policy landscape within Breast Screen Australia. We also had all of the data required to manage the trial in terms of client details, contact details, and we managed the mail out. So, and we basically were able to provide that real world setting for the trial. And then the services brought expertise in the client experience and the service delivery. So conversations with radiographers, etc., about explaining to women how the trial would work and how it would fit into that real world setting. Next, I think there's some extra bullets on that slide, which was cheating from me. It is not. So I was, with respect to the challenges of performing the trial, the biggest issue for us was the consent process. We were initially hoping to have a opt-out trial where most clients would be included in the trial unless they actively opted out, but that wasn't approved by the ethics committee. And so we ended up with an opt-in, which made the process a lot more convoluted, and it had an impact on timeliness of the trial because we didn't get the opt-in rate that we would really have liked and we would have got if we had had an opt-out. There were some challenges with managing the trial alongside our business as usual processes. One of the main things that we did in the trial was provide alternative letters, results letters to clients. And that is set up in a particular way that we had to kind of go outside of that process, which sometimes created problems. And we did have a small number of complaints about the trial. Most of those were fairly trivial. Some of them were just complaining that the message that we sent looked like it was a spam, for example. We also had some complaints where people thought they were in the trial, but they weren't for some reason. And obviously we were able to deal with those. The benefits of the trial are this is a world first RCT, and given the policy landscape as it stands, it might be the only ever RCT on this topic. We've been able to use the expert knowledge of the academics to develop our resources that we can use to inform our clients, and if breast density is notified to Women Australia, then we'll be able to use the information that we've gained from that process, and that evidence will inform the rollout of notification in Queensland. And I guess lastly for us, just that improved credibility and reputation for the breast screen program, working with researchers just gives us some credibility within the program that we're kind of pulling our weight and we're adding to the research base. Thank you.
Thanks so much, Nick. That's such a fantastic example, and I'm sure people will have questions about it in the Q&A. So I am now pleased to introduce the next speaker. So Dr. Jonathan Dartnell is the Managing Director of QUM Connect and also the Co-Director for Quality Use of Medicines Alliance. His presentation title, as you can see, is Quality Use of Medicines Alliance Collectively Addressing QUM Priorities. So over to you, Jonathan.
Great. Thank you very much for the introduction, and good to be part of the program today. So Wiser Healthcare, QUM Connect, my organisation, and 6 consumer and health professional organisations are part of the Quality Use of Medicines Alliance, and that's a consortium which is focused on improving medicine use in Australia. The Wiser Healthcare colleagues we're collaborating with are Rochelle Bookbinder, Denise O'Connor and their team from Monash Department of Clinical Epidemiology, along with Kirsten McCaffrey and her team from the Sydney Health Literacy Lab and Sydney University. The work of the Quality Use of Medicines Alliance sits in the context of Australia's National Medicines Policy. That policy includes pillars for regulating medicines in terms of quality, safety and efficacy through the TGA, supporting access to affordable medicines for those who need them through the Pharmaceutical Benefit Scheme. And then there is also a pillar underpinning quality use of medicines, which focuses on safe and wise use of medicines. And the Quality Use of Medicines Alliance has been awarded Australian government grants to support national action to improve medicine use in some specific areas. Our model brings together organisations with different expertise through shared governance and a co-design process towards a common goal. And our belief is the collective action approach should achieve a stronger audience engagement along with more enduring improvements in quality use of medicines. Next slide, please. Over 2 years, we're addressing 4 areas of care, including atopic dermatitis, gout, antidepressants in older people, and oral anticoagulants. We have an iterative process that we're moving through. WISER is contributing to many stages, but with particular focus on the research underpinning the design of programs, as well as the evaluation of impact and outcomes of the programs. Next slide, please. So for each topic, we have a rapid and iterative research and design process, which occurs over about 4 months for each of the top 4 topics. On the left-hand side of the slide represents the formative research undertaken to understand the quality use of medicine, or QUM, problem and inform us about best practice gaps, barriers and enablers to better practice, and what else is happening in the environment. On the right-hand side represents the program design process, in which the research outputs are viewed through different lenses to characterise the issues and identify potentially useful interventions. And we then have a group co-design work, which is undertaken to agree what QUM issues should be addressed and how we address them. So supporting this, Monash University is undertaking the desktop research and environmental scanning. Sydney University is undertaking qualitative research with consumers. We also have University of Wollongong undertaking qualitative research with health professionals, and QUM Connect is leading the program design side of that work. Next slide, please. As an example, this is a summary of research insights for atopic dermatitis, also known as eczema. A general point for QUM is often we find that first-line therapies are not used optimally, reducing their potential benefits, driving greater uptake of second and third-line therapies, or even non-evidence-based treatment, which is increasing out-of-pocket expenses for consumers alongside of PBS and system costs. And in this environment, low-value care thrives and high-value care declines. In the case of eczema, first-line recommended care is for use of moisturisers for foundational care and topical corticosteroids for flare management. There are many drivers of care in the case of eczema, often leading to poor use of first-line therapies and foundational care. For example, consumers may have misconceptions and concerns about topical corticosteroids as well as diet. These are promulgated very strongly on social media, and this is leading to avoidance of topical steroids and foods and onto more costly treatments. For GPs and pharmacists, communication with patients may be underpinned by legacy understanding of topical steroids and diet without adequate emphasis on foundational care. And then for dermatologists, they're having to redress the understanding and ensure use of foundational care. Slide 5, next slide, please. There isn't time today to go into the intervention strategy in any detail. However, our general approach across all the programs is to support better informed and shared decision-making. And we're doing that by direct-to-health professional education together with direct-to-consumer education, with a particular focus on implementing health professional mediated shared decision-making tools such as decision aids and patient action plans. Wiser Healthcare are conducting the evaluation for these programs, with Sydney University focusing on the consumer evaluation and Monash University focusing on the health professional side. And through that evaluation, we're keen to understand if we're making any impact on consumer and health professional decision-making, as well as whether high-cost interventions such as educational outreach are providing some additional benefit. So to do this, we're conducting a two-arm cluster randomised trial with Sentinel general practices randomised to different interventions. So to summarise, working in consortiums is harder, but the end result should be more enduring. And WISE's role is making sure that we build programs based on the best available evidence and that we conduct a sound evaluation of what we're doing to inform future programs and policy. Thank you.
Excellent. Thanks so much, Jonathan. Another fantastic presentation. And we're now going to move to the panel session where we're going to hear from 4 researchers who've worked with policy makers or health service providers. So can I invite the 4 people on our panel to please turn on your cameras and microphones? Thank you. So on our panel, we have Professor Denise O'Connor, who is a NHMRC Leadership Fellow and Deputy Director of the Wiser Healthcare Unit in the School of Public Health and Preventive Medicine, Monash University. We also have Dr. Brooke Nicol, who's a NHMRC Emerging Leader Research Fellow in the School of Public Health at the University of Sydney. And we have Dr. Danielle Coombs, who's a ECR Postdoctoral Research Fellow at the Institute for Musculoskeletal Health at the University of Sydney. And lastly, but not least, we have Adjunct Associate Professor Rebecca Haddock, who's the Executive Director for Knowledge Exchange at the Australian Healthcare and Hospitals Association, which is the national peak body for public and not-for-profit hospitals and healthcare. And Rebecca leads the work of the Diebel Institute for Health Policy Research. So thank you very much to all of you for joining us on our panel. And I'm just going to open the floor for some discussion about what each of you see as the benefits and challenges of conducting this type of research from the researcher side. What are the benefits and challenges? So Denise, you want to kick off?
Kick off. Thank you so much, Katie. And thanks to all the presenters as well. So I think there's, from certainly my perspective, but collaborators from the research side, I think there's sort of 2 key benefits of this type of collaborative research enterprise. And I think the first one is the potential to maximise the impact and sustainability of these interventions aimed at reducing low-value care or increasing the uptake of the right care. And that's because we as researchers are very familiar with the best available evidence on the drivers of low-value care and potential solutions and their effects, and also ways in which interventions can be designed to hopefully maximise their impact. And so by partnering, it gives us the best opportunity to do that in an efficient way, to bring in that all of that research evidence in a very efficient way and join with our policy colleagues. And I think it's particularly important for these types of initiatives, you know, those that have been illustrated and I can talk about with experience of working with Dina and her team and Jonathan and his team, because these interventions are deployed at a nationwide level. So obviously the stakes are high, and so we want to be maximising the potential for impact. And if they're shown to be effective, there's also potential for those to be sustained. So an enduring improvement over time. The second point that I think, you know, was touched upon by some of the speakers is about just building the generalisable evidence base. So all of these examples show basically embedding trials within existing initiatives. And particularly for the case illustrated by Dina and Jonathan, these are actually embedded trials of implementational research translation strategies. And so we really need to build that evidence base to be able to know what works. And that'll be helpful for people in different jurisdictions and also potentially to apply for different low value care problems. So thanks.
Fantastic. And so just before we move on to the next panelist, did you want to speak briefly about any challenges that you encountered from the researcher side and any of those projects or other projects that you've been involved in, and how you overcame those challenges?
Yeah, well, I mean, one that springs to mind is often the timelines for researchers and policy organisations don't line up. And so, you know, often there are pressures for, you know, researchers really to speed up their processes in order to fit in with those timelines for policy organisations. I think Dina talked about staffing, and changes in staffing can be a challenge sometimes. Well, definitely if there's changeover, and so there's not that sort of ongoing relationship building. Fortunately, with both Jonathan and Dina, we've had consistency or continuity of those. I think another issue is having insight into the policy priorities and you know, being able to line up where our research activities can actually feed into ongoing initiatives. And then I think finally being really clear about roles, responsibilities, and the decision-making processes, because if we don't have that clarity up front, we can sort of move along and not be clear about who ultimately gets the decisions or how we're going to make those decisions. So.
Fantastic. That's really clear. Thanks, Denise. Brooke, can we hear from you next, and perhaps specifically talking about your experience from the researcher side with the breast density notification trial?
Yep. Thanks, Katie. Hi, everyone. So I guess our trial is a bit interesting in the fact that I think as researchers, we were coming in looking at this as, you know, kind of a low value care overdiagnosis issue and wanting to gain some evidence on whether that was the case and what was happening in terms of notification, because there wasn't really a good evidence base internationally about the effectiveness of notifying women about their breast density, even though political landscape and consumer kind of pressure was moving in that direction. So we were kind of coming at it from that side, whereas I think Nick and his team are kind of coming at it from gaining that pressure and wanting to see what could be done. So we pitched to them that we were interested in doing some type of robust research. We'd already done early quantitative and qualitative research in the area, and we really wanted to move to that next step to gain some effectiveness implementation kind of evidence in real time to influence any policy and practice decisions that might happen in the future. So I think we really had to work together to co-design the intervention to make it work for what they were kind of wanting to get out of it and what we were wanting to kind of get out of it. And I think in the end, that was really beneficial for both of us, because it kind of landed at a spot where it was backed by good evidence and good methods in what we were doing, but also that it would be implementable in the future if that was the case, because they brought the Queensland Health team and the breast screen team kind of brought that real-time information to us that we weren't aware about and how it would actually work in practice. So that was really beneficial to have that kind of co-design process and work really closely with them in you know, not only kind of tailoring the research question, but definitely designing the intervention moving forward. And just in terms of, I guess, some challenges, Denise touched on it a little bit, but for us, the timelines was a real kind of issue because we knew the political landscape was moving fast in the area. And I think, you know, as researchers, we can kind of hit the ground running, do kind of research at our own pace when we're working in silos. But when you're working with external partners or people in policy or stakeholders in the actual services, it doesn't all necessarily work in that way. You have to kind of move at a pace that works for everyone, and there's sometimes changes in staff and things like that to deal with. But I think that's just the way it works in reality, and the benefits definitely outweigh that. We just did finish recruiting for our trial, which is really exciting, but the landscape in Australia has moved quite quickly. So while we do hope to inform what happens in terms of breast density notification nationally, it might be a little bit late for some of the major decisions. But internationally, I think it's still really relevant, and it's obviously going to inform how it's done if it does get implemented across Australia. So I think the timeline thing is you might go into it thinking your study is going to be a certain length, but there's a lot of external factors that kind of come into play when you're working with others. But yeah, a great experience, and kind of a different take from Denise's work in terms of getting that effectiveness evidence rather than looking at how it can actually be implemented.
Yeah, and it sounds like key to the success from your side was sort of openness to be adaptable and to try to find that sort of sweet spot of the win-win for both the researcher side and the policy or health service provider side. So fantastic. We might move to Danielle now. So do you want to speak to us a little bit about some of the research that you've been involved in to do with musculoskeletal health and the Agency for Clinical Innovation within New South Wales Health?
Yeah, thanks, Katie. Yeah, so the project that I worked on was the SHAPE trial, and with the SHAPE trial, we collaborated with New South Wales Health's Agency for Innovation, and we evaluated the implementation of their model of care, which they developed for low back pain. And we implemented this model of care into 4 emergency departments in New South Wales. So we designed an implementation strategy and evaluated the model of care by monitoring key low-value practices that are discouraged by the model of care. And so we were able to find that we're able to reduce opioid use in the emergency department, and without adversely affecting patient outcomes. So that's a little bit of a background, but in regards to the benefits of working with policy and health providers, I think the main point I wanted to highlight was the development of relationships and how that has formed future collaborations and future projects that have been embedded within the health service. So we have continued our relationship with ACI, and they've been partner organisations on other successful MRFF grant applications. We have a MRFF submission that's been recently gone in to try and optimise this implementation strategy that we had originally worked on and scale it into 44 ADs across New South Wales. And I think those relationships that we fostered within the first project that we worked on were really important and really imperative to working on these future projects.
Yeah, fantastic. And yeah, again, sort of echoing perhaps the projects that the others have talked about, that you can really achieve change at scale, and this can be a real powerful way to decrease low value care. Rebecca, I'd like to come to you now. So you're almost like a knowledge broker in a way in between the researchers and the policymakers or health service providers. Do you want to speak a little bit about how you see the value of these kind of partnerships between organisations to try to work to tackle low value care?
Yeah, sure. So the way we tackle our work is typically, I'll start with some examples that makes it clear for me. So typically we just have, we engage with academics who come to us with an evidence-based problem. And then we actually go and talk to the policymakers about whether that or not they actually see this problem, they're already doing something to address it, if they require more evidence, and then we develop the work based on the conversations that we have with policymakers. And so we typically have a couple of different outcomes from that process. So one being, I think you've all covered it actually, all the challenges and the value of the engagement. But one, I think, is that it's about finding that sweet spot in the time frame, in the policy window. So if you have the evidence ready to go, you're more likely to have impact with the policymakers. And so some of that really relies on knowing what the policy landscape looks like. And I think a lot of academics might know their policy landscape in their particular area, but what they don't actually realise is that there's a lot of moving parts that are actually going to impact on what policymakers know or want information on. So at the moment, there's actually 10 national frameworks that are all trying to drive low value care down. And so there's lots of different moving parts that they have to answer to. And so you kind of end up with three situations. One, either you hit them at the right policy window and you can actually get movement on your particular issue. And they love it to be evidence-based. Policymakers are always happy to talk to academics, but it really boils down to the communication, the style of communication. You can't go in and just give them an academic paper. You really have to think about how you're speaking with them. So designing that opportunity, I think that's already been mentioned. The other one is really, I think, really important that we see is flexibility. So I've gone to policymakers with a particular issue. So for example, we've gone to the Department of Health and said, we have this suggestion, and they've said, great, get us the evidence. And then we've gone to another government agency and said, we have this suggestion, and they said, we won't do that. And so you have to really be flexible. Academics really, really need to be flexible in what they're prepared to do. So I always kind of try and have some really feasible suggestions and a couple of blue sky kind of suggestions that, you never know when you're going to hit that sweet spot. The other thing to kind of think about, I think, is really, really critical is politics will always trump evidence. And so that's a really hard reality for academics. I'm an academic by background, and it took me quite a while to kind of really fully digest what that means. And when I say politics, it could be about, the policy window isn't right, the political context isn't right. So we're about to head into an election year that will impact on, what they're prepared to actually do, even if you've got the evidence. It's very fast moving at the moment, the landscape. We also don't know what policy platforms they're going to be putting forward. So when I talk about the political politics will trump evidence, it could also be between professional silos and service providers. And so an example of that, we did some work around specialist referrals and low value care. So people typically, we were finding children with respiratory conditions were having to keep going back to their GP for referrals to a specialist. This is low value care. It's expensive. It was time consuming. It was stressful for the families. There was a policy window to try and actually get some of these changes through the Medicare review, but actually the political beast that sort of sits behind the professional silo, professions, prevented any of those policy changes from occurring. So it didn't matter how much evidence we had to show it was low value care. You can't get it across if the politics isn't right.
Yeah. Although you can keep trying.
You can always keep trying, but I think you also have to know when to let it go. So I think the value basically boils down to they want to know what your evidence is. They want to know where the problem is. It doesn't matter whether it comes from the service provider, the academic. They want the evidence. They're time poor. They don't know the landscape. They can't access academic papers. So there's a lot of value in engaging. Just being realistic is, I think, the best advice I can give.
Fantastic. Really great advice. Thanks, Rebecca. So we've got lots of questions pouring in the Q&A. And welcome back, Stacey. And can we also welcome the 3 presenters who hopefully are still there to turn on their cameras and mics. And so I'll hand over to Stacey.
Thanks, everyone. Thanks for that great discussion. And thank you to the audience for your questions. So we've got some questions you might have seen sitting in the Q&A. We also have some that were pre-submitted. So I'm going to start with one of those from Jessie Zhang, who asks a really good question that is adjacent to what we've been talking about. We've talked about the challenges of doing this kind of collaborative work between researchers and policymakers. Jessie actually asked, what's the biggest barrier within health systems themselves to reducing low-value care? And how can these sorts of relationships help to overcome those barriers within health systems to work to reduce low-value care? I wonder if someone would like to take that question as a kick-off question. Denise?
Oh, I noticed Jonathan's hand went up, so I'll pass to him first, and then
Thanks, Jonathan.
Oh, thank you. Yeah, it's probably not a system-based response that I would give on that, but I think it really does depend on the problem that you're trying to address. And the first thing that comes to mind for me, if I'm looking at the atopic dermatitis program, is that for people with fairly severe eczema, that puts a fairly significant demand on them in terms of treatment regimens to be able to adhere to. And so putting a burden on patients with complex and demanding regimens, which can't be avoided at times, is the first thing that comes to mind. The other, we have a program on antidepressants, and I think, you know, that is a classic situation where it's easier to start something than stop something sometimes in care, and particularly around antidepressants. So I think clinicians are well aware of the problem of trying to deprescribe antidepressants, but really there should be a plan to stop when you start. And, you know, we're seeing really significant issues in social media that sort of develop like wildfire, and they're very hard to sort of address holus bolus. And I think we've got to do more work to support both consumers and health professionals in being able to manage those issues as they emerge. And we're seeing it with gout, and we're seeing it with eczema, and with some, you know, pretty difficult things to dissuade and consumers about.
Thanks, Jonathan. And Denise, did you want to follow up?
Well, I'd reiterate Jonathan's point that it depends on the problem, because we know that drivers or barriers to change can change or be different depending on what the low value care problem is, the health professional or the target, you know, group that for whom we want to influence or work with to support high value care, and also the context in which they operate and how decisions are taken and so forth. However, there has been, as a researcher, you'd expect me probably to talk about research, there has been an explosion in trying to understand the drivers or the barriers to change for low value care. And so there's been at least 3 systematic reviews that have been published in the last few years. And they cite some very common or frequently cited barriers, include things like health professionals often seeing patients or consumers who may have a limited understanding of the lack of benefits, and they may overestimate the benefits actually, and not have an understanding of the risk of harm of some tests and treatments. Health professionals talk about a disconnect between their training and the evidence. They talk about entrenched norms and resistance to change, which of course, you know, we know. And also a fear of malpractice is a big one that often comes up. And then the whole concept of models of reimbursement, that, you know, in the system we have reimbursement for low value care that obviously is incentivizing things. So, so that I can put the references to those 3 citations in the chat for people who are interested, but obviously you'd want to be looking at research related to your topic of interest also.
Perfect. Thanks, Denise. I might, in the interest of getting through a few people's questions, I might move on to the next question. And Dana, I think this is one for you. There's a really great question from Karen Price, which is effectively in the context of BERT, how do you decide what to focus on, focusing on over testing or under testing? How do you decide what's proportionate, like the burden on clinicians of doing an intervention? Can you speak a little bit to those kinds of weighing up judgments that you have to make?
Oh, most certainly. Hopefully my microphone is a little better this time. So one of the things we obviously do have a look at is, what kind of things are we looking at here? How risky is this kind of behaviour? We are working in the Department of Health and Aged Care from my perspective, and I do work in a compliance area. However, we regularly see all sorts of different things in our data, but it doesn't necessarily tell us what is occurring. So where we see that there are high rates, I suppose, of claiming that we are seeing, and we don't really understand why those things might be occurring, we decide proportionally about how we might intervene there. And this is this point about low value care. And so we try to work very closely with our peak stakeholders and obviously the evidence as well, from a clinical perspective, and say, well, what is happening here? So the design that we go with in our letters that we did send out for diagnostic imaging, for example, was looking at asking doctors to reflect on what is occurring. So we weren't actually saying you've done something wrong. It was just, here is some feedback, here is what we are seeing within the data, and you have the opportunity to reflect on your clinical practice, and where appropriate, you may wish to address some of those things and see if you can reduce some of those low value care issues. But it doesn't necessarily mean that they have done something wrong. And we have tried to be very supportive of GPs in that sense, which is part of the reason why we started collaborating with Wiser Healthcare.
Terrific. Thanks so much, Dana. So there's a couple of questions I'm going to pull together from the Q&A and throw to anyone on the panel who'd like to answer. There's a question about incentives. So how can we make doing this kind of work attractive, particularly in an environment where maybe sometimes it's hard to get funding to do this kind of work? And Paul Glaziou asks a really good question about how can we make the matchmaking really work? How can we put the right researchers together with the right health system actors so that we have a really effective relationship that will be productive on both sides? So I wonder if I can just throw it open to anyone, but I might start with Rebecca, because Rebecca, I reckon you probably do quite a lot of that matchmaking in your role. So maybe you could start there.
I do. I think when you are looking to engage with policymakers, it's really about understanding the nuances of your own policy issue. And so I think that then allows you to actually engage with the correct people. The other thing I would kind of flag is that it's really critical that you kind of work with a third party that actually already has those relationships. It's really hard to get traction if you don't have trust with policymakers. I think you're really lucky being in like the academic institutions already have like a level of inbuilt trust. They know there's going to be solid, rigorous evidence, but it's just about really, unfortunately, it's just a bit of legwork. It's really about understanding who's on the ground, who you need to be engaging with, and if you really understand the different components of your work, it allows you to engage, have maximum engagement. And so it sounds really simple, but often, sort of doing that stakeholder mapping is really critical part of the process. And so that all comes back to that idea of designing the opportunities. And so academics really need to be thinking about that right from the beginning, and not as a sort of in the final year of the grant, let's disseminate the information. The other thing I'll just flag is that there's been, I think somebody else mentioned this, there's been a huge amount of movement across the bureaucracy at the moment over the last 12 months. And so you constantly have to be looking and checking and keeping those relationships going. So it's actually like a big component of having to engage with policy.
Thanks, Rebecca. So we've got a couple of minutes left, and I might just ask if anyone else on the panel would like to talk about either incentivizing this kind of work effectively or getting that matchmaking working really well. Nick.
So I guess as a person that works in a Department of Health, I would encourage people to reach out to people that work in the department. I know that we have access to a lot of data, and we just do not have the time to do everything that we would like to do. And so if you have a good idea for something that you would like to look into, and if it aligns even somewhat closely, we'll jump on it, because we can leverage your questions to help answer our own questions. So reach out to people.
Thanks, Nick. And Denise?
I think just reflecting on, sort of the genesis of the project with Dina and the Department of Health and Aged Care. I mean, that really came from, I think, a phone call from, the department to someone in our research collaboration, an administrative person who then, forwarded up the chain. And it was discussed at one of our meetings, and then people who were interested and had relevant skills sort of could put their hands up and then have an initial meeting. So I think there was sort of self-selected matchmaking, but at the same time, we tried to bring in the right people with the right mix of content and methods expertise. And I think that's the benefit of having, I guess, being in research collaboration, is that it draws on and has made up of people with a whole host of different skills. And I think just in terms of incentives, if we think about if we were going to do this traditionally without having these partnerships, the costs of doing these types of research projects or trials would be huge. And so you think about, the incentives are that there is sort of modest additional costs in terms of design, co-design, and then actually doing the evaluation or leading the evaluation. And so therefore, that's an incentive, I think, in itself.
Thanks, Denise. And maybe just to finish off our questions really quickly, both Danielle and Brooke are early and mid-career researchers. Obviously doing this kind of work is a whole other ballgame when you're just starting your research career. Danielle and Brooke, have you got any advice for early and mid-career researchers who are thinking about embarking on this kind of work?
Well, I think the initial connections or matchmaking, to really lean on your supervisors to guide you in that, or people more senior. But then when you kind of have those relationships to really put effort in and put lots of kind of collaborative work into them to maintain them, because it can really be a leg to stand on for your career. I know for me right now, I'm writing a grant here in Australia for the NHMRC, and lots of what I talk about in my impact and in the leadership I've done has been as a result of this trial that I'm doing with Nick and the collaborations that I've formed and the partnerships that I've made through that. So we haven't even published our protocol paper and nothing else. So, there's still been a lot of impact that's been generated through that, and just really keeping those collaborations beneficial for both sides. Because I know Nick and I have talked about other projects. We've collaborated on other things as well now. And so just hoping he doesn't move on anywhere else. But I think even if they do, that you have those contacts kind of for life if you put the effort in.
Thanks so much, Brooke. And Danielle, we've only got a minute, but any thoughts from you?
Yeah, I would agree with what Brooke said in regards to relationships, and again, working with your supervisor and working with, experts to help you with that.
Thanks, Danielle. So I'm going to pass over to Katie, and we're going to wrap up. So over to you, Katie.
Thanks, Stacey. So I'd like to thank all the presenters and panelists and all the participants that have joined in to listen to this fascinating discussion and great showcase of the impact that these kind of projects can have to really prevent overdiagnosis and reduce low-value care at scale. I'd like to also mention that the next Preventing Overdiagnosis webinar will be held in September. We don't have the exact date yet, so stay tuned for that. And to also remind everyone to save the date for the 2025 Preventing Overdiagnosis Conference, which will be at Oxford University from the 3rd to 5th of September next year. So hope to see some of you there. Thank you very much, everyone. See you.